No, I would like to. Assalamu alaikum, everyone, and a very good morning and a warm welcome to one and all. So thank you for joining. It's an early weekend morning, and this is a super interesting topic because obsessive compulsive disorder is something which comes in many facets. So some of us, we already know that we are very particular about timings. Some of us are very particular about what is right, what is wrong. Some of us are very particular about walking in a straight track and nobody comes and overrides our car when we are going. So some of us like everything to be clean and nothing to be contaminated. And during COVID, it became like more than what it could be true. So today's topic is very, very important, which is obsessive compulsive disorder. We have often talked about the fact that obsessive compulsive disorder can also be seen in slightly obsessive people, like obsessive compulsive personality disorder, also known as an ancastic disorder. So I don't think anybody could have been more eminent to present this than Dr. Shahid Qureshi, who is a very renowned consultant psychiatrist in the NHS, and he's also the WPA Deputy Secretary General. So without a further ado, I would leave the floor to him, and thank you for presenting this to us. Dr. Shahid.
So much. First of all, let me correct. I am not a WPA Deputy Secretary General. I was until 2021. So I think this is an error. I did ask the organizers to correct it, but perhaps it was too late. Basically, I'm a psychiatrist working in the NHS, and I'm going to talk to you today about cognitive behavioral therapy in OCD. So I hope that most of you would know what CBT entails, because I'm not intending to talk about what CBT is. So I will talk about CBT and OCD. I will touch basically briefly about OCD to remind ourselves, but I'm not going to speak a great deal about OCD either. I think the chair has already touched upon what OCD is. OCD has obsessional thoughts and leads to compulsions. And she did touch upon the differences between obsessional personalities and severe obsessive compulsive disorder. Obsessive compulsive disorder is a very serious and disabling condition if not treated in time and appropriately. Today, this is a workshop, this is not a lecture, so I would like to be interactive. And people who are sitting in the back, they might want to come in front. I understand that time is not enough to run this as a proper workshop, but I will try my best if we can use this workshop rather than a lecture. Therefore, I've given the first slide. This is for you guys to look that what CBT in OCD might involve, and then we will discuss about it. Basically, you spend first 5 sessions to prepare, and from 6 to 13 sessions you do exposure therapies with the patients that they can learn and manage. You are not going to completely eradicate their obsessional compulsive disorder or obsessional thoughts, but what we are going to eradicate is their disabilities and how it impacts their everyday functioning. And then from 14 to 17 session, you are going to do restructuring, and from 18 to 22, perhaps you will work on relapse prevention. So here is a case study. I would like you to think about this case. And whilst I'm talking to you about different techniques that what we do in OCD, then keep this case in mind and try to work in your mind that what you will do with this kind of a patient, because this patient will come at some other stage during this workshop as well. At that time, we'll dissect what we can do. And maybe if there is a time, we can do some workshop in groups. This is basically a 32-year-old single male who is a father of 4 and currently not working. He is presenting with 6 months history of constant checking with doubt that someone might break into his house. And he's washing and cleaning for several hours a day. This has caused a significant distress that is now affecting his relationship and ability to cope with day-to-day life. He spends more money on detergents and soaps than on his food. So his priority has changed. Rather than food, he's spending a lot of money on detergents. This has caused him to sleep less and has developed problems with neighbors and police due to constantly checking his doors at night time, because neighbors are worrying what the hell is happening, this man, why he's checking his doors at night time. He has a past history of borderline personality disorder, but there is no medical, family, or mental illness otherwise. He described his childhood as being difficult due to problems at home that we do not know. So are we all, you got it? And there's no recent history of alcohol or substance abuse in this case, although he has used it in the past. He is single at the moment, but has formed new relationships. But he and his partner are not living together. They're living separately because she cannot cope with his behavior. He has no current problems with the law, but has been advised by police to carry a letter explaining what his condition is, what he suffers from, that police may deal with him sympathetically. Whereas he appears distressed and preoccupied with the thoughts of cleaning and doubts that someone might break into his house, these thoughts have caused him to respond by checking and cleaning. So that is all the main issue. And he has insight and he's wanting a treatment. He wants to get better. So any thoughts before how would you like to? You don't have to answer, maybe think in your heads. If anybody wants to say anything, I don't mind. Okay. Now I'm coming to the, yes, I'm sorry. Yes, sir.
If you like to say in the past history of borderline personality,
But,
is it resolved?
well, past history of borderline disorder, he's 32 now. Many people believe that borderline personality disorder in some cases, disappears with time. So we assume that that is the case. Rather than looking at the whole, dissecting the history, we assume that main problem at the moment is obsessive compulsive disorder. It's a good question, but I just wanted to focus on, thank you. So basically now coming to the workshop, I will cover what the OCD is, basically diagnosis. We'll touch basically the causes, what causes it, and review and make thorough assessment of factors responsible for maintaining OCD. Review and develop understanding of a cognitive model of OCD, and review CBT treatment. Now, we are not going to be able to observe role play today because of the timings. Therefore, I have already given you that what you call case history. Maybe think about it. And in the end, if we can sit in groups that see where we reached in managing this young man. And then what we call develop a treatment plan and detailed intervention. Well, I'm not going to dwell too much about diagnosis. In simple words, obsessive compulsive disorder is a recurrent thoughts that keep coming into a person's head. against their will, despite resisting them, and this causes them a distress. This is what it is. This is maybe a little old, and this is what the changes are. Changes are only in terminology. You will note that they have included now obsessive compulsive spectrum disorder and uses urges instead of impulses. This is the term. And previously they used the word inappropriate thoughts, because these are not inappropriate thoughts. These can be appropriate thoughts, but unwanted, undesired, not needed. And they have come with a severity scale as well, whereas previously it was thought that it's on the continuum, and many people believe that OCD was not that disabling condition, but it is, and modified inside specifier as well. There's a slide, at the bottom you can see DSM-5 criteria you can go and take. By the way, when I finish this, you can ask the organizers to give you my slides, because it has references as well. So, well, there are subtypes. Now, contamination and washing, this is the one that we most, come across. And harm checking as well, that I might cause a harm to a family member, or my family member might come to harm if I did not do such a thing. There are pure obsessions without overt compulsions, but they are covert as well. Covert, and particularly, I'm in Abu Dhabi, which is a Muslim country, and I'm myself Muslim, so I'm aware that covert, some blasphemous thoughts about religion or Allah or any other significant person in the faith. There are other subtypes that we know that people work in symmetrical order, do things in an orderly manner. And hoarding is another thing. People collect things, otherwise they might not present with significant distress, but if you go into their houses, I do not know whether you, those working in this country, psychiatrists, have an opportunity to go and see patients in their houses. I have worked as a consultant in home treatment team for several years, so I used to go and see patients in their homes. A person may be having a diagnosis of schizophrenia, but literally it will be impossible to get into their house because they collected so much clutter. And we know now that obsessive compulsive disorder can cause slowness as well. That we know is obsessional slowness. Now, symptoms of OCD, obsessions we talked, these are thoughts about contamination, aggression, and other thoughts can be blasphemous thoughts, and other thought can be I'm stopped at the railway station waiting for a train, might think I might fall, and many things that may come into person's head which are not wanted. And that thought leads to an act with what we call compulsion. And compulsion, if it is contamination, people wash, like in this person's case that I have submitted, that he has been using a lot of money on buying detergents and soaps rather than buying food. And then another, people want to achieve control. If they did not do this thing, something might happen. People count certain things or, chant certain rituals as well. These are involuntary and intrusive and persistent thoughts. These can be images and impulses, although I have said that impulses word has been removed. These are not inappropriate because this is from the previous, so these are unwanted. Ego dystonic. I mean, I'm sure you know the term egosyntonic and ego-dystonic. For those who might be trainees here, ego-dystonic is a term used which is not compatible with one's own personality. That, egosyntonic are those things that may appear bizarre to other people, but, they are compatible with our personality. And these are distinguished from worries. So people are able to differentiate from normal worries because they identify them, their own thoughts keep coming into their head. And the other element is that they try to resist it. They don't want it. And they know that these are not right thoughts and want to not have them. And they identify these as one of their own thoughts. Individual attempt to suppress, ignore, or neutralize them. Compulsions, I've touched upon that these are basically an action in response to the thought that comes into person's head. And these are repetitive neutralizing behaviors, neutralizing in the sense that they think that by repeating these thoughts, the thought that had come into their head might go, or the belief that that has created might not happen. But in reality, it reinforces their belief and also it causes an added distress. And these can be overt, like checking and ordering, and covert, like praying, chanting, or sometimes counting as well. And these basically, I have said, I'm repeating myself here, they're responses to in response to the obsessions. And the aim is to reduce the distress. Aim is to prevent a disaster from happening. Now, these are the guidelines from UK. I'm not sure these will be relevant here, but when I talk about whether they are relevant here, I did attend lecture here by one of your Abu Dhabi lady, Dr. Nadia, I think. She talked about some government policies, so step care does exist here as well. Basically, what step care is that, services are provided in different steps. From step 1 to 6. 6 is the severe, where inpatient or specialized services will be given. 5 would be that maybe inpatient and partly home treatment team support. 4 will be community-based services. 3rd will be that, psychological interventions rather than necessarily psychiatrists getting involved. 2 will be GP and nurses and psychologists. And 1 will be self-help. So I don't want to spend okay. Thank you. So basically, aim is by using the step care is that understand the condition and to know the systems are in place that is providing continuity of care and provides information and treatment and tailored to the individual needs rather than and in keeping with patient's cultural and religious background. And it's very important that families are involved. I've touched, so we're not going to do, these are the basically step care. Causes, I think, again, I will refer to Chair. She did talk about anencaustic personality disorder. I mean, some believe that it can be normal. I mean, I think most of people sitting here would be doctors or psychologists. And we are doctors and psychologists because we would have some obsessional traits in ourselves that we, in the university, sat down and read the books and followed a particular curriculum. If we did not have obsessional thoughts, then we would not be what we are. So in some cases, it's very positive and it is normal. And some psychological conditions can cause, and I'm not going to dwell upon it, that many psychiatric conditions can have an obsessive compulsive as a symptom rather than a disorder. So when you treat the primary condition, those obsessions will disappear. And can be a learned behavior that, I've learned certain thing, from my parents or teachers. And I did say just now that functional illness, if I have suffered from another mental disorder, that people can have what you call obsessive symptoms as secondary symptom rather than a primary symptom which will disappear as you will treat the primary condition. And some neurological, conditions. Anybody can think of any particular area in the brain which can cause OCD? Yeah, thank you. Thank you very much. It is not relevant, but I thought just, bring it here. Basically, the conditions that we know, the post-encephalitic Parkinsonism, Gilles-Dila-Tourette syndrome, and Sydenham-Chorea, and the area which my colleague just mentioned, these are central cortical areas. Now, I think we did talk about OCD. Now we talk about CBT, for which mainly we have gathered here. Now, sorry, it's me. I tried to, was fiddling with the. Basically, this is from this man Kozak. This is Kozak's formulation. So, what he's talking and saying that there was a problem in a childhood and then adolescent, those problems came and started giving assumptions and beliefs that if they did something, they can prevent a disaster. And then intrusive thoughts come into patient's head, attention, and they reason them, and they try to neutralize them. And sometimes, not sometimes, most often they misinterpret them, and it brings mood changes, and it leads to some safety, safety, methods. Now, initially I said I'm not going to talk about CBT. Basically, what CBT is a systemic, short-acting, brief psychological intervention which provides psychoeducation. It works with thoughts, emotions, actions we do, and bodily symptoms. Basically, this is what he's trying to, because it's not clear, I thought. Now, assessment, when you socialize for the OCD, I'm responsible for contaminating myself and others. But think about that young man that we just presented. He is constantly getting intrusions. He's anxious. He's seeking reassurance. He's washing hands. Obviously, it has affected his mood, and screening for signs of contamination all the time. And there are worries and ruminations. Now, this slide is from Institute of Psychiatry. This is not a rocket science. This is a very straightforward questionnaire. When you are seeing patients, you need to do a full psychosocial assessment, starting with how did the problem start, what kept it going, what were the main intrusive thoughts. Now, here specifically about thoughts. What are the specific intrusive thoughts, urges or images that bothers the individual, and how that person is interpreting those thoughts. And what did you learn about the problem that was useful, and how the treatment has helped you to deal with the difficulties. The person may have had difficulties and had some other treatments. What were your most unhelpful thoughts and assumptions, predictions? Describe the most helpful behavior experiment, what you learned from them, both in the session and outside them. So when you're completely assessed, and these are things that you have to do each week when you're seeing patients, you ask them these questions to learn from your perspective that what is working and what is not working, that you can decide that how quick or how slow your sessions should be or would be. And then checking how they are achieving their goals. Another main CBT skill is that the way you talk, Socratic questions that you do, and make an interpersonal relationship with them, and keep on summarizing what you have learned from them and what you did in the previous session, and then what you aim to do. So setting an agenda as well. I think I've touched upon this. Basically, this is the whole history that you need to do. Assessment of intrusion are contaminations. Object might be infected with lethal germs. Violence to self and others. I will harm my children. That is one of quite worrying thing. I saw a patient. The patient thought that he was going to have a sex with their 4 years old child. So it can be very distressing. You just imagine. In death, images of loved one being dead. That if I did not do this, my mother or my father or my brother, my wife might die. Unacceptable behavior. I might start thinking that, I'm having these thoughts about Allah, and in masjid if I go and shout, how public might react. I mean, Arabs are perhaps more civilized. I'm from Pakistan, and if somebody shouted obscenities in Pakistan in masjid, that person might be assaulted or attacked by the mob. So there are consequences of these things as well. Right, I have touched upon I'm going to molest a child. Religion, images of devil. Intrusion, some questions. So how we check the intrusion. When was the last time you had that thought? When was the last time you washed or check? But ask for a recent example. It is always important to ask for the recent example. Then ask next question, what else they were doing, where they were, who else was with them at that time when they were doing that and that thought came in their head. When that thought came into their head, or when they were washing, what went through their mind? What is the first thing they noticed around them? And the thought that came into their head, imaged out as response, was it into response to what they were thinking, or was not in response? Here I'm talking about mindfulness, where the person is able to engage in mindfulness, because people who are able to engage in mindfulness, it's very easy to work with them. Where as person is so preoccupied, it will give you an indication that how much preoccupied that person might be. And did this thought image go through your mind suddenly and against your will? Does this thought image occur to you frequently? And one thing I think should be here, which is not here, which is part of the definition. If it did come into your head, did you try to stop it? What did you do not to have it? Because it's part of definition that they try to resist these thoughts. Now, appraisal of intrusions. When these things come into their head, they feel inflated responsibility. They give too much importance to thought that goes in their mind. And it is that inflated responsibility and importance that they gave that is the main cause that leads to them to act and compels. So I will go back to what I said in the beginning. Here, our aim and objective might not be to completely get rid of their obsession thoughts. Obsession may keep coming. It is our aim in CBT to help them how they can manage these without affecting their everyday life. Now, I might be saying some conflicting thing that, I'm talking from a CBT perspective. As those who are psychiatrists sitting in this room, I am one of them as well. we might think differently, that we might want to treat it, and that they don't have it, so we try to treat it with medication as well. So I think it is important to keep in mind that we have a dual responsibility. If we are psychiatrists and providing that CBT, that we take responsibility of their medical illness as well as their psychological needs. But if it is only those who are sitting here, psychologists, only providing psychological intervention, they need to be mindful of that as well and make that decision that whether there is a need to get a psychiatrist involved. So sometimes those symptoms can be so, strong that you will not get rid of them without any medical intervention. And what they do is they start giving too much importance to their thought that if they did not act on it, something serious might happen to what they believe. So different terms have been used by different people. Thought-action fusion is a term used by Reckman. Wells has used a term, thought-event fusion and thought-object fusion. Now basically they are the same things, because the thought is so strong, a belief is so strong that they think that if they did not do it, something might happen. Beliefs about the importance of controlling one's thoughts, and they think that they should control it to prevent from the disaster happening. They always overestimate the threat. They have intolerance for uncertainty. They can't wait. And they want things to be perfect. And there's another saying, I'm slightly drifting. They say that, people with obsessive compulsive personality disorder, they will never reach to the top. They might be second best person, but not to be the top man, because they always want to be perfectionists, so they will be slow. So they need somebody to always manage them and to guide them. It's just, I'm not, don't believe in it. You don't have to believe in it, I'm just, okay. Belief examples. Now these questions again are from Responsibility Attitude Scale, which was created by Salwowski in 2000. And Salwowski basically is a CBT therapist. I often feel responsible for things which go wrong. I don't act when I can foresee danger, then I am to blame for any consequences if it happens. To me, not acting to prevent disaster is as bad as making disaster happen. So this is like a from thought fusion instrument. So thought becomes what we were talking earlier, the terms. Basically, term means that if they did not act, something is going to happen. So thought is fused with the action or event. If I think about an unpleasant event, it will make it more likely to happen. If I have a thought about harming myself, I will end up doing it. When I was training, that time, that was a common belief that people with OCD did not kill themselves, but it is not true. They do. And there was other belief, I'm just distracting here, that ladies in pregnancy, if they had OCD, they perhaps will not suffer from a serious OCD, and that has been proven wrong as well. I'm just talking about when I was training. My feelings can be transferred into the objects. Responsibility. Am I too slow or too fast? Please. I normally speak very fast. I'm a very fidgety person, so I'm trying to control myself today actually, because I want to do this thing in time. And I do not know. You don't believe. A lot of my colleagues tell me that I have ADHD. But you may think that I am very calm today. The belief that one has power, which is pivotal. Basically, this is the definition of when we talk about thought fusion, thought event fusion, thought action fusion. I think this is kind of close to what we said. The belief that one has power which is pivotal to bring about or prevent subjectively crucial negative outcomes. These outcomes are perceived as essential to prevent. They may be actual, that is having consequences in real world, or at a moral level. For peace of mind, resign as a general manager of the universe, if this is what helps to tell the patient, but it is not easy. It's easier said than being done. Some questions from Wells. When you thought, how did that make you feel? It sounds as if having that thought feeling meant something negative. What did it mean? How much do you believe having the thought means that? It seems as if thought is important, what's important about it? So thought is important, but what is it about thought that is important? What is the worst that could happen if you continue to have a thought? What does the thought say about what you as a person? Does the thought have any special significance or meaning? Is having a thought harmful or dangerous? So when you're doing it, you're constantly checking, doing the risk assessments as well. And did any of the thoughts enter your mind when you felt anxious? So when they were already anxious, did any other thought enter in their mind as well? If beliefs are not accessible, the common analogy can be used is what we all do in our daily life. When we are driving, when we reach to a traffic light and traffic light is red, we immediately stop without thinking. And thing is that you have to challenge it to the OCD person. His thoughts are constantly running like a car, but he is not able to stop it because he is constantly worrying about thought. And just think that, if we did not stop at that red light, I think this happens here in this country as well, but in England where I come from at the moment, even it's 2 o'clock at the night time, there is no traffic coming from right, no traffic coming from left, no traffic coming from front. If there's a red light, we'll stop. In Pakistan, if the red light, traffic coming from here and here, people still go. So what I'm trying to say that, it's a risk assessment that people have to do. Risk assessment that people have to do. So we stop it as a normal human beings. We stop it because we are worried about the consequences, and they can't, because I wonder if your OCD is similar. You challenge the person because they are fearing that if they did stop, there might be a crash. And they are like Pakistani drivers. They just want to go through and want to get home quickly. So I'll go to bullet 5 here. If I were an unethical researcher who wanted to confirm what your fears are in relation to stopping at the red light, what kind of experiment could I do? How about I tamper with the brakes? If I tamper with the brakes, what will happen? I won't be able to stop, which means that I'm going to have a crash. Your car rushing towards the busy junction. Using the same principle, how could we find out what fears lie behind their rituals? You use that, then maybe learn where beliefs are not accessible. Here, I want to use another, technique which I have not included it. Those I'm just reminding. I'm not going to dwell upon it because I would expect that most of you would know what CBT entails. Have you heard about downward arrow and upward arrow? If you ask upward arrow is questioning, you come to the
hierarchy?
Yes. And the downward will take you to the belief, the roots, deep-rooted roots. Tell me about it. Tell me about it. What does it mean? Tell me about it means that upward questioning, it will lead to what is a thought, and downward question what does it mean? What does it mean will take you to the belief. It might not be obvious to a patient themselves. It's called downward arrow and upward arrow technique. As I said, I'm not going to talk about CBT as such because I hope that people who are here will know. Okay, assessment of behaviors. We talked about, okay, sorry, this has come second time here. Behavior, some questions. When you thought, what did you do to prevent? When thoughts came, what are the behaviors they did? When thought came into my head of any kind, what did I do? Did you repeat things, do things in a special way, or avoid situations? There's another thing in the definition we touch. The persistent thoughts which keep coming to the patient's head despite not wanting them causes an anxiety and leads to an avoidance as well. It's like a phobia, Did you try to control your thoughts? And if so, how did you do that? How often do you engage in these responses? And how much time do they take? Talk about this. Now, going back to that, case. Think about that case, that what would you do that I've already discussed with you. Okay, when you have asked all these questions, you have come to an assessment. Now, the next thing is that we need to develop a formulation. We need to develop a formulation. Before we develop a formulation, it is important that we develop a formulation together rather than alone. It's a collaborative work with the patient. We doctors don't do it, but psychotherapists and CBT therapists do it. They will have a piece of paper and they'll be writing things, making drawings and doing it with the patient, and they'll see it together. Here, maybe a thought affecting their emotions, what kind of behaviors it has led to you, what physical consequences are. So if you're doing it with the patient, you're doing it together, sharing a formulation together, considering formulation as an alternative, non-threatening explanation. Because it's a patient's story, patient has told you. You've not created anything from yourself. Like doctors, we give a diagnosis. In CBT, you're not giving a diagnosis, you're reaching to a conclusion together about a problem. And then identifying ways how you are going to work to achieve what you want to achieve. Employ guided discovery to enable service user to develop a deeper understanding of the formulation. I think when you're assessing them, the questions, they are specific to CBT. There are some general, questions that we all ask in our, what we call everyday practice, but in CBT, you specifically ask about thoughts, you specifically ask about emotions, you specifically ask about behaviors, you specifically ask about how this has affected. And then guided discovery that, what it has done to them, the way it has affected them. Discussing how changing certain elements and formulation are responsive can help service user to achieve their short-term goals. It is them that you will be work together rather than you being prescriptive. It is your questioning style, how you ask them questions. Socializing an OCD, vicious flower, the first one that I showed you at the beginning. I'm responsible for contaminating myself under this. What it did in that picture, it caused an anxiety. It caused intrusive thoughts. It demanded a reassurance. Patient wanted to be reassured and led to certain rituals. There were worries, rumination, and he was constantly screening for the signs of contamination and depressed. Then, when you socialize it, you challenge their thoughts, but thoughts are not going to go away. You have to do some behavioral work. And behavioral work might involve exposure in real life and exposure in imagination. And implementing exposure exercise with ritual prevention. And sometimes you deliberately provoke the obsessions in imagination by repeatedly writing down. When one thing, which I think I'll cover at some other point, but when you are involving patients into any exposure work and imaginal exposure, make sure that you give them longer time than your 60 minutes, because you make sure that before they leave your consulting room, they are not as distressed as they otherwise would be, because it can be very risky. Listening repeatedly on audio tapes, loop tapes with obsessions, which the patient has recorded themselves. Maybe imagination, it might be difficult, it might be easy for a phobic person to think, close their eyes and look if you are at the height or standing at the cliff. But a person who's also having difficulty in their thoughts, it might be difficult to ask them close their eyes and think about something. So you may have to, ask them to write it down that they can read, or you ask them to video record or audio record. So I think I did touch this as well, that particularly when you are doing some imaginal work, you make sure that you give them longer time before they can go home. And then normalizing the intrusion as well. There can be some positive, some negative. And are these positive and neutral intrusions? Some are not always positive. Most of the time they are not. Are there any negative intrusions that are not so bothering? How often do intrusions occur? Are intrusions useful? What is the purpose of intrusions? What would happen if we responded to all these intrusions? What would happen if we responded to all the intrusions in the same way that we respond to most distressing ones? So maybe challenging them that they can change their response. And how do people know what intrusions to respond to? Then, when we're doing behavioral reactivation now, verbal reactivation, challenging and changing them, appraisals of intrusion, theory A and theory B labeling, responsibility beliefs, pie chart. Do you know all these pie charts? Like a big chart, how much is a stress on how much? Thought fusion beliefs, and asking Socratic questions. I'm sure you know the Socratic, ask question, listen, summarize, and then ask synthesizing question. And perfectionism, continua. Do you know what continua is? Continua is another technique in which you help patients to challenge their own unwanted thoughts and unwanted beliefs about themselves and about world around them. You ask them to write it down on a paper, 3 boxes, what most distressing, least distressing, and in the middle one that they can see and choose. And lack of motivation, then you do cost benefit analysis, that by keeping these, what is the cost, and by losing them, what is the loss? Behavioral reactivation are exposure and response prevention with emphasis on challenging beliefs, to disconfirm fears, and then you work on habituation to increase meta-awareness, try alternative strategies. Responsibility contract modeling. Motivation, again, use this as an insurance. Losing, most of us these days have a home insurance or life insurance, and but our insurances don't cover everything. They don't cover, even travel insurance that I have today will not cover me for if I go on a risky sports. So if some insurance company is giving you all the risk that is going to be covered. It's going to be very expensive. So their beliefs for them are very expensive to lose, because if they lost them, then they think that they are going to run into a risky situation. And this is why they keep their obsessions and compulsion, because that's their safety. Now, relapse prevention, when we have completed everything, then we have to spend a few sessions working on relapse prevention. What did they learn about OCD? What keeps it going? And how they have learned to deal with it? Are they in a situation that they have not been confronted? Consider incorporating them in relapse prevention plan. And what could cause a setback? Because setbacks are possible and will happen. And how could setback be useful? And when there is a relapse, where they are going to get the help from. Important thing in relapse prevention is to help them to identify the signature signs that can be seen and identified. And if they did not respond, then they are going to get the fully blown condition again. Right. Then other thing is that I did give an example or question earlier, that what was going through your mind. Were they able to distract their thought when they were washing their hands or not? So we need to train them to use mindfulness as a skill. By mindfulness, they can manage their obsession. And there is some study which suggests that it has been effective. Stimulations with their own obsessive thoughts through headphones, and instructed to deal with their obsession thoughts using either mindfulness-based strategy or distracting technique. Assessment of anxiety distresses urges to neutralize on visual analog scales, baseline experiment conditions, and during return to baseline. Basically, this is evidence. It is saying that it does work. Important thing is that you can use mindfulness in refrain from any rituals during exposure and everyday life. After each exposure, the ritual that was prevented is banned. Explore and enhance motivation for cost and benefit analysis. Encourage self-monitoring. Obsessions are also evoked in some mediums such as a narrative, script, slides, audiovisuals. And consider imaginal exposure. These are things that you try to tell them that they can do when they are discharged. Service user fears involve images. The consequences of avoiding the rituals are perceived as disastrous. In vivo, exposures cannot address the feared consequences. You will need to socialize the use of imagery. Develop and use material that elicits obsessional distress. Pay attention to the emotional significance of the material used. Encourage the user to tolerate distress until it decreases, and tolerate your own distress. Now, this is not going to happen. Basically, I come back to this case study that I started with. What I've done is basically to go through, assuming that most of you have had a basic CBT skills and understanding, to use the questions that we discussed in different situations. What are the questions that you will use in this 32-year-old man who is father of 4, who is currently out of work, and he is presenting 6 months history of constant checking and doubts. Someone might break into his house and he's washing and cleaning for several hours. This has caused significant distress that is now affecting his relationship and ability to cope. In obsession, you noted there are two things. One thing is constantly checking, and second thing is washing. The two things, checking and washing. And he spends more money on detergents. Other thing is that he's spending more money on detergents whilst cleaning his hands. And for checking, it has caused him a problem with the police. I'm just, reminding rather than going through the slides again. It has caused him a problem with the neighbors and police. And police has asked him to carry some letter with him telling him how to protect yourself from more complaints by public. So I do not know whether we have a time. It's 7 past 11. I think we have got 23 minutes. If you are willing, you can, in group of 5 to 6. I think easily there can be 5 or 6 groups that we can sit.
I think that would be a good idea.
That, only go through the questions that we have done. And I'm happy to repeat those questions that I have just shared with you, and ask the, and then ask the organizers, they can share my slides with you as well. Are you willing to do this?
So I think we have, maybe they might not be able to group up because these are like chairs. How about like some portion of people, like here or something, maybe people can sit together, because this is interesting. There are lots of questions. How would you approach? So maybe a case has been given already. Maybe some of the questions that might be posed to that person might be very interesting.
Yeah, I mean,
Can you show the, yeah, I think this.
if you got it, then what I can do is to take you back to that, session-wise, that things that you do that can help you to do things in a systemic manner, because workshop is about learning the skills.
Yes.
It's not a rocket science. But what I've said to you, still you might wish to choose your own ways. There are no right ways and no wrong ways.
So Dr. Qureshi has given like that downward questioning style, the upward questioning style. So somebody is spending more money on detergents and soaps than on his food. And this is causing his sleep to be affected and problems with neighbors and police due to constant checking. So somebody is constantly having a checking problem. How would you approach this patient, maybe? Just some questions, random questions, I think. Questions, anything?
Are you not going to discuss about yourselves?
I think that's good.
I think ideally, because of the time, because we don't have a time, usually in workshops we need 2 to 3 hours.
Yeah.
That even the questions I did very quickly. Otherwise each stage we should have practiced those things together. Because we are not able to do that.
Yeah, I think you've got a variety of audience where there are psychiatrists, psychologists, and there are trainees as well. So, they have got a varied experience. But I think in any way or form, what you would do is to gather more insight that what is the severity of the condition and what impact it is having. We do have some idea that he's already having problem with police and, the neighbors and all. But in terms of the personal effect, how much time is he spending on these thoughts and how frequent and what is the kind of, how much is he trying to resist and how successful he is in doing that. All that you want to have a good idea, and it might take a few sessions for you to get, especially if there are, there are compulsions and as well as obsessions. And if it has been there for some time, then you would want to see whether, there has been a treatment before, what worked, what didn't work for him. So yeah, I think that will be the starting point.
Very interesting.
Thank you. I think Dr. Aisha
Yes, Dr. Aisha Afzal.
covered that we would make an assessment. Once we have completed the assessment, we are going to ask the questions. She touched upon the important points, that how these things are affecting the person's life,
So-
and how much time that person is going to spend. And I think that she did touch upon that, what disabilities it has caused him. Yeah, anybody wants to add?
Yes, the duration, the frequency, and intensity. For the assessment and for the progress also, we have to check this. Yes.
So the duration, how long you have been doing it, the intensity and the frequency, how often you do it, and you said how long it has been, what is the intensity?
But duration is not only the
How long?
but duration is how much time that person spends.
Okay, so how much time is spent, how long you have been doing it. Nobody wants to know why you are doing it? Anybody? Yes.
Hello, thank you so much for this presentation, by the way, and this workshop. I think it's amazing. What I was always having an issue working with the OCD in my therapy sessions is, first of all, depends on the people education. Sometimes the question that we are asking can be extremely complicated and they can't go because of the overwhelming thoughts. So exactly, the pure question why is sometimes the simplest one to go with. The second one that I had a problem is to differentiate the belief system and superstition from OCD. So it's a very thin line where they actually switch from the superstition and belief system that we are carrying from the family or the background, social background, and from believing, for example, never throw up the trash in the middle of the night because of whatever, to actually start obsessively think about those things. And I would like to ask you, maybe this one is not that particular case, but my question will be, when you actually how you distinguish that thin line and how you're working with them?
Okay, thank you. I think I'll start by, you said education. People's education might not be adequate. So I think when I started talking about step care, guidance, it says that you have to tailor it to individuals' needs and their cultural and social background. And with the CBT, everybody is not educated. You can't tell them to use the internet. Still, people in Pakistan, I'm sure in this country, they will not be able to use the internet for the self-help. So what you have to do is to do drawings, or ask them to audio tape or write it down, or maybe making some toys. To answering your question about superstition, what is the thin line? I think it is basically it's a full psychiatric assessment that you will do, and then you'll decide whether a person has an awareness. It is important person who is engaging. I'm only talking about OCD. I'm not talking about, because sometimes when you say thin line, it's very difficult. I've seen people who were believed to have OCD, but in actual fact they had schizophrenia because their belief systems were so severe and so deep that was not obvious. It takes a lot of time. It's about constantly asking questions, constantly checking their beliefs. You are not going to offer anybody OCD if they don't have access to their thoughts. When we talk about suitability of what you call CBT, person has to be able to access their thoughts, number one. Person has to be able to accept the treatment. Person has to be able to willing. So when you talk about thin line, I think it is something we as a doctors and nurses and psychologists, psychotherapists, CBT therapists, we have to draw a line that when we recommend something to somebody, because we may recommend some treatments which might not be adequate for them. So to make it simple, I'm not sure if I'm answering your question. It's about doing...
I'd like to add. Dr. Dina, very, very nice point made there. So magical thinking is one of the defenses that has been mentioned in the textbooks, which is seen very common in OCD, in patients with OCD. So people do come up with these kind of thoughts. For example, every time that I wear green, something good happens. It happened once, it happened second time, and then you start finding your basis. Then the next thought comes is, if you don't wear green, something bad will happen. So this is something that goes on. So if you do something, I have always seen, there is Chinese mythology about putting lemon and salt, and then things they ward away, and then it works sometimes. And then you start feeling that that is what works. Right. So these thoughts are some things which are very commonly seen in patients with obsessive compulsive disorder. And that's what Dr. Qureshi had mentioned. What caused it in the first place? How did it start? How did it progress? So this is something that is there. And really,
I'm mindful of the time as well, because I think we have to cover a few things. We have, assume that we have done the assessment. Then how you're going to check the goals? I mean, that's the important thing, because you are not going, because CBT, if that involves patient wanting it, it's the patient who wants something, not that we want something to happen to the patient.
Absolutely.
How you're going to analyze the goals? What question that you'll ask? I'll ask the front line.
Any ideas?
Look, trainees. Are they trainees or psychologists? Psychologists.
Wow,
oh,
mashallah.
then you are most expert.
The experts.
Yeah, experts.
So what are the goals?
What are the goals that how you're going to deal with it?
Of CBT?
First of all, we think of if they want to reduce the intrusive thoughts or the behavior, so the goals are if they want to reduce it, and what are the severity of the diagnosis, the disorder itself.
So basically,
and how it is affecting their life.
Good. Thank you. I think what we are learning from our psychologist colleague, that goals we are going to learn from them, what are their goals, what is that they want to achieve, whether it is a thoughts or actions, and how much it is distressing them. Okay, anybody else wants to add anything?
That's a great point. That differentiates between OCD and OCPD at times, that some people like to be cautious and they would find it as ego syntonic, that it's nice to be cautious. But in OCD, the person here in this case is preoccupied with checking, which is impacting his life. So one of your goals can be, if it is a patient's goal, of course, the patient makes that to reduce the frequency of that behavior, which is what you said.
And this colleague not only covered the analysis of goals, but behavioral analysis as well. That she did mention that the behaviors that are affecting and how they want to change them. Okay. So if problem is chronic and developmental, as has casual factors, previous learning experiences, behavioral analysis of symptom level, implementation of simple diaries for self-monitoring. What are the things that you will put in? I mean, as I've not talked about whole course of CBT, but I presume that you have been doing CBT. So what are the things that you would like to add? I did mention, yes, sir.
I think I'll give
Thank you. I think, yes, here in behavioral analysis, we need to focus with the clients about his or her thoughts before acting the compulsive behaviors, and also about his thoughts, emotions before and during the compulsive compulsive behaviors acting, and after that. So we need also to know all the 3 times before, during, after. And also in behavioral analysis, I think it's also a good question to know, or to use the scaling questions. For example, could you please tell me out of 10, how you feel anxious. The client maybe can answer you that I feel, for example, 7 out of 10 anxiety, like that.
Okay.
Yeah, thank you.
Thank you very much.
Absolutely. So the thing is, very well said. Obsessive anxiety, which leads for a person. So I think that was a very nice point made, Dr. Qureshi, that maybe what is the thought behind a particular behavior, and what happens. So it's worry and anxiety, which is making you do a compulsion. Followed by that, there might be sense of regret. Oh, I again gave in. So this is interesting.
So we have covered assessment of obsession, now coming to the compulsion. So this man's case, checking and watching, what are the exposures that you would like to advise or discuss? If he's spending, say, too much time washing his hands and spending more money on buying detergents than buying his food, and he is checking so frequently that has affected his relationship with the neighbors have contacted the police, and police has warned him that carry a letter from a doctor, Aisha Afzal, I'm sorry, I like to, one of my things is that I like to relate to.
Remember the names.
No, I relate to the people. When I talk,
Great.
I relate to the people. That,
That's very nice.
a letter from her that, this man has a OCD, that police is not punishing this man for his behaviors. So what are the, behavioral techniques that you would put into place or recommend? I've just given some list, but these are just for your prompts rather than, but we specifically think about this person. You can pick one problem, either washing or checking, whichever.